Hello, I'm Dr. David DeRose, your host for American Indian and Alaska Native Living. And as part of our new season of shows, we're rolling out some bonus video content to go along with our radio show that we've been producing for nearly 20 years. Today's guest is Dr. Greg Steinke. Some of you know Dr. Steinke. He's a hospitalist in the Chattanooga, Tennessee area, and he's been a guest with me previously. He's also one of my co-authors for the book I wrote called 30 Days to Natural Blood Pressure Control. So Greg and I know each other well, but it's great to have someone who's been on the front lines of this COVID-19 pandemic who's actually sharing some good news. I know just mentioning COVID-19 has got some of you maybe yawning, maybe reaching to look for another video. But hang in there, because although we may have, well, some of us may have felt like we've heard as much as we want to hear, there really is some good news, and Dr. Steinke is going to be sharing that in what was part of the first segment of this edition of American Indian and Alaska Native Living Radio. You'll see the video content coming up momentarily, but I want to encourage you to watch the entire episode. Well, at least listen to it. The audio component of the video can easily be accessed on our website. It's called American Indian and Alaska Native Living, simply AIANL.org. So AI for American Indian, AN for Alaska Native, then the letter L.org. So if you go there, you'll be able to listen to the entire interview, about an hour in length. Well, enjoy this portion of the presentation, the video content with Dr. Greg Steinke. Welcome to today's show. I'm Dr. David DeRose. I'm excited today to have a great friend and colleague joining us. His name is Dr. Greg Steinke. Greg, it's wonderful to have you on the show again.
Hey, thank you, David. This is really exciting to be able to cover some of the details with COVID-19 and some of the other things we're going to talk about today.
Well, you're exactly right. Our topic for today, at least as we begin, is the good news about COVID-19. Here we are recording this segment in September of 2020. And I'll be honest with you, as my listeners, I was kind of thinking, well, like many of us, that come fall, maybe this would all be behind us, looking back some, 6 months ago. But we're still in the thick of things, at least in many places in the United States. And Dr. Steinke, you are still in the thick of things because you are a hospitalist working in Chattanooga, Tennessee, and you are actively caring for COVID-19 patients. Isn't that the case?
That's right. And David, when it first started, no doubt the hospital was on edge, and there was a lot of reorganization that occurred. And I had the opportunity to get involved with starting to see the COVID-19 patients that started coming in. In Chattanooga, we were kind of late to the game. We were hearing about the significant outbreaks in the east and the northeast. But when it came to the south, we really didn't get a lot of cases until June, July was really where we had a major peak in cases. But it's significantly come down. It's probably cut by half now from what it was in terms of the amount of people in the hospital at any one time.
So some parts of the country finding just what you're finding, other places still seeing rising numbers as of our recording of this show. And I guess the big question, Greg, you and I, as we spoke about doing this program together, you said you want to get out some of the good news about COVID-19. So from the perspective of a hospitalist, what is some of the good news?
Well, I think the number one thing that I've come to realize over the last multiple months is that when we first had the opportunity to hear about it from China, and so on, we started realizing that this was a pretty serious thing. We were hearing 20% hospitalization rates. We were hearing, 4 or 5, maybe more percent of people dying who got it. And it scared everybody significantly. But as we've been going through this epidemic, as the data has been coming out, we're realizing that it is in fact less serious than we first thought. No doubt people are still struggling with it. No doubt there's still plenty of people being hospitalized, but it's the percentages are not that high. And the reason for that is that we have a lot of asymptomatic infections. What we're actually learning in the US is based on a 10-site study that came out in July across the US from the COVID-19 data from the CDC, that probably somewhere about 40% of cases are actually asymptomatic. And so you have to adjust the numbers based on that. And so certainly we're looking at, less than 10% hospitalization rates. We're looking at, less than 1% death rates. And that's good news. We got that first inkling of that good news, if you remember, in February with that Diamond Princess cruise ship that had a big outbreak on it down near Japan. They had about 3,700 people who were on that ship, and they had over 600 people who ended up becoming a case. But what they realized is that those cases were actually almost half of them were asymptomatic. And it was pretty good news in that most of those people were over the age of 50. And so that was a first little inkling. For a long time, we weren't sure about what was going on there. But that's a lot of good news that we have a much higher asymptomatic rate. We have a much lower hospitalization rate than we thought. It's not 20%. It's significantly lower than that based on the antibody testing.
So this is great news. So basically what you're sharing with us, Greg, I think is putting things in perspective that many people, and I think this message has been getting out, many people really don't get noticeably sick at all with COVID-19. Now, the flip side of the discussion, and I think we have to speak about this, is there have been people from the beginning, kind of the naysayers, if you will. Most of them, at least in my experience, I'm not going to say all of them, there are health professionals in this group, but most of them are not health professionals, and they've been looking at numbers. And they're saying, well, look at all these people die from influenza. There's people dying from COVID-19. This just looks like a bad flu. We've heard that comparison, and there's been messaging where people are trying to distance themselves from that rhetoric, people in the healthcare community. So what about this comparison that people have been making from the eyes of a specialist, a hospitalist? You're taking care of sick people in the hospital. How does this compare to a bad flu season as far as what you're seeing?
COVID-19 has features to it that you just don't see in flu. We're seeing more problems with the blood clotting system in this illness. We're seeing a more frequent problem with prolonged issues with pneumonias and breathing than you see in the flu. In the flu, you can typically have a week-long hospitalization, often shorter, but we often have patients who are there significantly longer than that, especially if they land themselves in the ICU. A 2-week hospitalization is not atypical at all with these cases. So yes, I believe this is a magnitude of threat higher in terms of its strength on the body. There are certainly some other things going on. There's a problem that we're seeing with the way the immune system is interacting in some people, where there's this excess inflammation that's occurring. And so we are doing what we can to minimize that inflammation. And the interesting thing, David, is that a lot of these people coming into the hospital are actually in their 2nd or 3rd week of illness. They sometimes are not even having, substantial fevers anymore. Their fever curve is starting to die down, but their shortness of breath is worsening. And that's some of the interesting details that we've been seeing with this illness.
What I'm hearing from those folks on the front lines, like yourself, is that totally different in the ERs, totally different in the ICUs compared to the seasonal influenza, like you've mentioned. So there is this difference, but we're seeing good news in spite of
the greater severity of the disease. And I guess one of the questions about good news, first maybe we'll go to that population you mentioned, the intensive care population. I know early on it seemed like there was great anxiety to get people on ventilators, breathing for them. It seems like that pendulum has shifted. We're not hearing a lot of talk about ventilator shortages. What's happened as far as our management of breathing problems in these individuals?
We've realized that because many of them are able to maintain a good level of consciousness, not everybody, but many of them are, we can just focus on their oxygenation. So we are able to, put them on, regular oxygen, and then we start to escalate the vigor of the oxygen as needed, and that saves people from being having to go on a ventilator many, many times. So we've kind of shifted from thinking at first that these folks were going to need to be intubated and placed on a ventilator right away to delaying it as long as possible, because we're just seeing people do a lot better. If they're on a high flow oxygen situation for a couple of days, sometimes a week, they can be on it. They tend to get through it, and it's interesting that it's their lungs that are so often giving them trouble. They'll start to feel better even in some ways, but their lungs are still injured and still unable to get the oxygen in. It was interesting in terms of the ICU, looking at what New York experienced. We heard a lot early in this pandemic that New York city hospitals were going to be overwhelmed, that they were significantly in trouble. And when you look at the data, they were able to increase their capacity a bit. They were not overwhelmed. At the worst of the epidemic, they still had 1 in 6 hospital beds open in New York City. At the worst of the epidemic, they still had 1 in 10 ICU beds open in New York City. And so the New York City hospitals were not overwhelmed. And that's good news, that we haven't run into a situation in our country that I'm aware of where people were basically being kind of left in a situation where they were unable to access the usual services.
Now, Greg, you and I both know in Indian country, historically, a strong emphasis on natural therapies. As I've worked with First Nations peoples throughout North America, it's very fascinating to me to see just the variety of natural therapies that have been used, everything from what we might call hydrotherapy to herbal therapies to other lifestyle-based therapies. Talk with us a little bit about the hydrotherapies. I know you've had a special interest in this, and you're doing even some pilot work. Is that what I understood, as far as some studies looking at the feasibility of using some of these techniques basically with COVID-19?
Yeah, David, when the initial research was coming out of China on COVID-19, there was a study that was really remarkable, that was showing that patients who were hospitalized who did not have a fever were 60% more likely to die than those who had a fever. And so that data, along with prior knowledge related to the changes in temperature and the effects of temperature on your immune system when you have an infection, led us to go into this pilot study that we're doing. We have just about 20 people in the study so far. And what we do is we heat up their chest for about 20 minutes, twice a shift. And then we put, after the 20-minute heat session, we put a cold, wet cloth on their chest for less than a minute. That serves as a heat lock to keep that heat in there. And so we've been doing this, on these patients, and we'll see what it shows. We don't have any data back yet, but I'm interested in the fact that as you get the temperature to come up, I've been aiming at giving it to patients who are making inadequate fevers. They should be making a fever, and they're not. and so we're trying to stimulate that and help their immune system to do better. We know that there's certain cells in the immune system that when they are heated up, it helps them to focus in on the attack. It helps them to become more vigorous, and then it also helps those same cells, cells called macrophages, that are very abundant in your lungs, to actually go into a calmer and less inflamed state through the effect of fever. And that may in fact be why the death rate is lower when you have a fever.
This is fascinating stuff. We want to talk more about the exciting news about COVID-19 and about other topics as well. It's not exclusively a radio show that will just look at this cutting-edge topic. We've got other great information with Dr. Greg Steinke that you don't want to miss. I'm Dr. David DeRose. We will be back with more right after this.
Well, that's all for our video component of our weekly radio broadcast called American Indian and Alaska Native Living. Hopefully you enjoyed that. And like I said at the beginning, check out the entire interview. You've listened to really essentially the entire first segment of the show. 3 additional segments, though, in the audio portion. I don't think you really want to miss it. Dr. Greg Steinke's got a lot of great information. You can listen to that at your leisure. Download a podcast at aianl.org. That's for American Indian Alaska Native Living.org. I'm Dr. David DeRose, your host, and as always, wishing you the very best of health.